Hi, this is Jen Livingston for the Week 3 case study. Based on the information, here's a problem representation and an illness script. So problem rep, I've got a 67-year-old black female presenting to the ED with chest pain that began last night and is described as pressure unresolved by antacid and unprovoked upon palpation or movement. She has a history of a murmur, hypertension, and well-controlled diabetes. She denies heavy lifting or trauma, fever, chills, and extremity pain or swelling. She was admitted for observation to rule out acute coronary syndrome. The ED course includes vital signs 140/78, 108 beats per minute, 16 respiratory rate, and 95% on room air. Her labs had a glucose of 129, her first troponin was negative, and her BMI is 38.1. Illness script for mitral valve regurg, epidemiology. Regurg is the most common form of valvular heart disease, and the incidence increases with age. Risk factor includes congenital defects, MI, Marfan syndrome, mitral valve prolapse, untreated strep, and some diet pills. Thomas Heaton and Makairis, 2022. Pathophys, a faulty valve allows the return of blood flow from the left ventricle into the left atrium. This movement of blood causes the murmur. Primary causes include failure of the valve due to damage or deformity of anatomy, and the secondary cause would be a ventricular wall motion issue. Doughty and Doughty, 2022. Clinical presentation. Acute mitral regurg presents with shortness of breath, worse with laying down, cough with frothy, perhaps blood-tinged sputum, radiating chest pain, altered mental status, hypoxia, tachycardia, hypotension, and tachypnea, and the MI. Acute bacterial mitral valve regurg may present with signs of sepsis, neurofocal defects, and Janeway lesions. What is subjective versus objective data? Subjective information is that which is reported by the patient, as in the problem representation above, there's subjective data in there, and it additionally includes, in this case, a past medical history of a cardiac murmur, hypertension, well-controlled diabetes, and high cholesterol, denial of anxiety, a GAD-7 score of 1, and a denial of depression. Home meds of aspirin 81 a day, amlodipine 10, metformin 1,000, and atorvastatin 20. Allergies include lisinopril with a reaction described as angioedema. Social history, she has a 23-pack year history and denies illicit drug use or alcohol use. She is a retired librarian and lives with her daughter and her family. Family history is a mother who had diabetes and is now deceased, hypertension, coronary artery disease, and her father had AFib, heart failure with right ejection fraction, reserved ejection fraction, a CABG times 3, and her daughters have diabetes. Objective information is collected by the provider and includes physical assessment, labs, imaging, and clinical studies as included in the illness script, and additionally includes, in this case, a female who appears her stated age with obese body habitus, normocephalic perla EOM intact, respirations are even, unlabored, and breath sounds clear throughout, normal active bowel tones, all 4 quadrants, no hepatosplenomegaly, which I think is kind of hard to palpate on an obese patient. But she moves all extremities without difficulty. Her heart sounds are auscultated irregularly with holosystolic murmur, best heard at the apex and radiating to the axilla. Her peripheral pulses are 2 bilaterally, and she's alert and oriented to person, place, time, and situation. My initial differential on subjective information was ACS and PE. Additional data that I would like to collect would be a D-dimer, a CKMB, an EKG, a CBC, a BMP, a UA, and to cycle troponins, get a stress test, and a TTE. I would want to know if she had past episodes of chest pain, any angina diagnosis in the past, if she'd had any other cardiovascular events or workups, try to get those records. I'd wonder if she had nausea, upper extremity pain, neck pain, or diaphoresis. I would want to know if she had recent surgery, travel, or other incidents of unusual immobility. If she'd had any hemoptysis, I'd complete a PERC score, and I'd want to know if she'd ever been told she has a congenital heart defect. I'd auscultate some heart sounds with hand grip, squatting, and Valsalva. And I'd wonder if she'd ever had a recent history of a sore throat or a history of strep throat. And I'd wonder if she was using any diet pills, and if her symptoms were exacerbated with laying down, if she had a cough or any sputum. And a differential based on objective would be ACS, PE, mitral valve regurg. The inclusion of her vital signs was mildly positive, though the data set is incomplete for PERC score per BOCA 2020, and including heart sounds places mitral valve regurg on the differential. I did not anchor on a diagnosis without significant supporting or corroborating evidence, because I've been surprised enough by diagnoses and also seen firsthand how things can go if you miss things. I actually worry a little bit more about settling on a diagnosis promptly and with reasonable utilization than I do about anchoring. I did not use research articles insofar as the references I used are not reporting on current research. They're more references for information on disease presentation, process, and treatment. At this point, I find myself using those types of references more so than using, current research articles about certain things, just because I feel like I'm, really just needing to know what the standard cares are and what the best current practice is. Open-ended questions are, what new research did you find that might inform standards of practice? So did you come across anything that you would maybe take back to a preceptor and say, hey, what do you think about this? And if this patient were to ask you about her prognosis, what would you tell her? Thank you.